Hi, I'm Dr. Joseph Romagnuolo. I'm here to talk to you about our recent paper in gastrointestinal endoscopy, EUS in patients with surgically altered upper GI anatomy. This paper is first authored by Dr. Jason Wilson, who is one of our core fellows here, and he did most of the real work on this project. He, again, is the first author. The other co-authors are Dr. Rob Hawes and Dr. Brenda Hoffman. The study was done at the Medical University of South Carolina in Charleston, in the Digestive Disease Center. I'm an associate professor of medicine and the director of clinical research. The study reports on almost 200 patients that were found in our endoscopic ultrasound database of over 13,000 EUS procedures. These were patients who had had some surgically altered upper GI anatomy and were referred for endoscopic ultrasound. The purpose of this study was really to see whether some of the limitations that apply to ERCP in surgically altered upper GI anatomy also apply to EUS, and also to assess the safety issues that might be specific to EUS, and to some extent the feasibility of FNA through surgically altered anatomy. There's obviously some literature of the feasibility and adverse event rate in ERCP in these patients. And there is a high failure rate in Roux-en-Y anatomy and a moderate failure rate in Billroth 2 anatomy for ERCP, with a known increase in luminal perforation risk, but it's admittedly small. In EUS, the feasibility and adverse event rate is really unknown, and so that's why we look back at our experience in these patients. In these 190 patients that we did, there were no adverse events, and when you calculate a confidence interval around that, we're 95% sure that the real adverse event rate is likely under 2%, which is pretty reasonable, but higher than the significant adverse event rate that might be for a typical EUS patient with normal anatomy, especially if the real rate is at the higher end of that confidence interval. Now, the procedures were generally successful, and not surprisingly, the limitations were mainly of imaging the head of the pancreas and the bile duct. The head of the pancreas and the bile duct was almost never successfully imaged in Roux-en-Y patients, other than one patient who had gastric bypass, who had a staple line dehiscence that we were able to get into the native stomach and through the pylorus and get to the head of pancreas. The other patients were generally unsuccessful at imaging that area. And not surprisingly, in Billroth 1 or post-esophagectomy patients, the imaging of the head of the pancreas or the bile duct was almost always successful, as it would be in patients with normal anatomy. And in Billroth 2 patients, that success rate was intermediate between those two scenarios. Of the 40 or so patients that fell into that category, about a quarter of them didn't have imaging in that area indicated, and of the rest, about 2/3 of them had successful imaging, sometimes with FNA. Now, imaging in a Billroth 2 patient has sort of backwards imaging anatomy compared to what you would see normally in a patient without surgically altered anatomy, and a figure of that is in the paper. In contrast, when we're looking at the body and tail of the pancreas, there was virtually no limitations in imaging in any of these patients as long as you were able to get through the esophagus, for example, in post-esophagectomy patients. You really could almost always image the body and tail well. And so if the indication was to look at chronic pancreatitis or to look at a FNA or exclusion of a mass lesion in the body and tail, that was almost always successful. We were even able to do a transpouch FNA of a pancreatic tail lesion in someone who is post-gastric bypass, and in general that seemed to be feasible and safe. In some of these patients, blood vessels and other air-filled structures that are usually not in the way will sometimes get in the way. And in the Pew-Stowe patients, there was some air artifact that is in the body and tail of the pancreas, both in the duct and around the pancreas, that sometimes limited imaging in those patients. Now, there are some limitations to our study, and one of those is the fact that this was retrospective. So in retrospective series, trying to assess the reason why an area wasn't imaged or why an FNA wasn't done is not always perfect. In most of those cases, we could tell what was intended based on the indication and history that was listed. But in some cases, we had to make a judgment call as to whether the FNA would have otherwise been done, or that area would have otherwise been imaged if the anatomy wasn't surgically altered. The other limitation is that this was done as a single-centered study in a tertiary center with experienced endosonographers. And so both the success rate may be overstated and the adverse event rate may be understated. And so those rates may not be completely generalizable to other centers and really needs to be reproduced in other physicians' experience. We didn't look at luminal abnormalities that might be amenable to a mini probe when an FNA was not needed. And that's another limitation. We also didn't look at therapeutic procedures other than celiac plexus blocks, which were almost always feasible in the patients that we looked at. And so that's another limitation. Looking back on the procedures that we did, what are some of the tips that we could offer? One thing is to not attempt to intubate a surgically altered limb if you don't feel that it's indicated. We're trained to do a thorough exam of the pancreas when we're looking at the pancreas in someone with normal anatomy. But in some of these patients, if the head of the pancreas and the bile duct imaging is not critical to the indication of the procedure, it may not be worth the risk to attempt to intubate that area where there's a higher than average chance of failure and likely a higher than average chance of an adverse event. We always try to limit the amount of air that we put in when we're doing EUS. But especially in this circumstance where putting in air, especially at the beginning of the procedure, can fill up downstream loops of bowel with air that may get in the way of imaging later in the exam. So really have to be cautious about putting in air in these patients, put the minimal amount of air that you need to get where you need to go safely. There are some blind turns when you're doing patients with this surgically altered anatomy, and that's an uncomfortable situation, especially with an oblique viewing scope as opposed to a forward viewing scope. The echo endoscopes are oblique viewing, and so you don't always get that same view that you get with a forward viewer. And some of the turns that you have to make have to be done very cautiously. Sometimes what looks like a sharp blind turn might actually be in reality a blind end of a piece of bowel, and so obviously advancing in that area has a high risk of perforation. It's obviously more efficient to go down with the scope that you're ultimately going to use. So if you anticipate that you're going to perform a celiac plexus block or that you're going to need to perform an FNA, that it's probably worthwhile to go down with the linear scope up front as long as you think you have a reasonable chance of getting to that area successfully and there's a reasonable to high chance that you are going to find the lesion and have to FNA. You generally don't want to intubate that surgically altered limb more than once if you can avoid it. So you'd rather not go down with a radial and then have to come back and do it all over again with the linear. Generally, EUS and FNA is a very, very low risk procedure. But in these patients, two things have to be conveyed to the patient. One is that it has a higher than average rate of failure of imaging certain aspects of the anatomy, especially the head of the pancreas and the bile duct in certain anatomy. It's almost never successful in Roux-en-Y, and so perhaps shouldn't even be attempted in some of those patients if that's the indication. But it has certainly a lower than average success rate in Bell-Roth 2 patients compared to normal anatomy, and that should be, and patients should be informed of that up front. Also, even though we didn't find any added adverse events, there's certainly a theoretical, there's theoretical reasons for this patient population to have a higher rate of adverse events, especially if perforation in accessing these surgically altered limbs. And so that should be conveyed. Again, in our series and in probably other experienced hands, the rate of a serious adverse event appears to be under that 1% to 2% range. But again, that rate may not be applicable to all settings. And I think one of the future directions that this should take is for this to be confirmed in others' hands. So in conclusion, I think we've nicely described a fairly large series of patients that were sent for EUS who had surgically altered upper GI anatomy and shown that in general it's very successful. And even imaging the head of the pancreas and the bile duct in most anatomy is successful most of the time. And certainly the body and tail and things like celiac blocks are almost always successful no matter what the altered anatomy is, but there are certain limitations and certain precautions that need to be taken. We hope that this added information will help referring GI docs, referring primary care physicians, and referring surgeons know when to send somebody for an EUS who happens to have surgically altered upper GI anatomy, to know what the limitations are in those patients, to know that there may be a high rate of success where they thought that EUS might not have been feasible, and to know that there is at least a theoretical risk for an added adverse event rate. And although we didn't see any adverse events in our series, I think there is an increase in risk, especially of perforation in theory in these patients, and you need to be cautious and need to make sure that that EUS is indicated. And one needs to be sure that when you're accessing surgically altered limbs, that access is a necessary part of that EUS procedure. Thank you.